Well, hello, everybody. Yesterday we talked about what's new in chemotherapy and biologic therapy in 2010, and I promised you the piece on somatostatin analogs I would save for today, so that's what we'll do. We'll talk about that a little bit. The importance of somatostatin analogs in 2010. So first of all, before we talk about somatostatin analogs, let's talk about what is somatostatin. Somatostatin is a natural hormone that the body produces that stops the growth and also stops the hormone secretion of neuroendocrine cells. That's its job, a turnoff. However, it is destroyed in the body within minutes, making it highly impractical to use as a pharmaceutical agent because you would have to kind of walk around with a continuous intravenous infusion to have much benefit from a drug that is so short-lived. So what has happened is that somatostatin analogs have been developed. Somatostatin analogs are modification of the natural somatostatin molecule, which allows the substance to survive for long periods of time and remain functional for a long period of time and not be so rapidly degraded by the body. These modifications of somatostatin are called somatostatin analogs. These are the drugs we're going to be talking about today. To date, octreotide, which goes by the brand name of Sandostatin, and the long-acting form known as LAR, have been the only somatostatin analogs generally available for the therapy of carcinoid syndrome for quite a while. They're highly effective in the management of diarrhea and flushing associated with metastatic carcinoid tumors, and in fact it's for that purpose that they have been approved by the FDA in the United States and have been approved for in most of the world. A very important clinical trial was just published within the past year, known as the PROMID Study. The principal author of the study was actually supposed to be at the meeting today, but was unfortunately unable to make it, but I will try to remind everybody about the importance of this study. Using octreotide, somatostatin, not just in treating flushing and diarrhea, but the PROMID study was designed to use octreotide as a therapy, as a chemotherapy if you like, but without the normally expected side effects of chemotherapy since this is a natural hormone. So the PROMID study was like this. 85 patients with midgut carcinoid tumors, these are carcinoid tumors of the small intestine, mostly in the ileum, were randomized to receive either octreotide-LAR 30 milligrams per month or placebo. All right? The endpoint of the study was called progression-free survival. In other words, how long can your cancer remain completely under control without any sign of growing cancer in your body? That was the endpoint. The median time to progression was 14.3 months with octreotide and 6 months with placebo, a difference which is very, very highly statistically significant. And as many of you know in the room, it isn't always 14.3 months, but it actually can be enormously more than that. And in fact, when people have been relatively stable before they started octreotide, in other words, they had surgical resection already and had only minimal amounts of disease left, or had particularly slow-growing carcinoid tumors, okay, the stable disease rate at 6 months was 64% with octreotide and 37% with placebo. Again, an enormous increase. So this has really established octreotide as a therapy for cancer, not just as a means of controlling flushing and diarrhea, which has enormous implications because there are many insurance companies, for example, that have been denying off-label use of octreotide and considering treating cancer an off-label use. It's now a cancer treatment as well as a symptomatic treatment. Okay, so that's what's new with octreotide. However, octreotide has to be given by a deep IM injection. And even though my nurses are extraordinarily gentle, the thought of an octreotide injection coming to enter the rear can often be a source of tremendous anxiety. And I thank my nurse Faye for these images of nurse and patient. To deal with this issue, a new substance has come along, which is another somatostatin analog, somewhat similar in its effectiveness to octreotide, but it can be given by a subcutaneous injection, which is much less of a trauma than a deep IM injection. This is called Lanreotide Autogel. Lanreotide Autogel is an interesting thing. It's made by taking just lanreotide and water and mixing them together under pressure. It spontaneously associates itself into little nanotube microstructures on a molecular basis when it's mixed with water and put under pressure. And these little nanotubes are pretty stable, and they slowly release octreotide. And at the end of the day, Lanreotide, and when all the Lanreotide is released, you're left with Lanreotide and water. There isn't really any other vehicle to make it long-acting, and it's a whole different world than having to give a depot injection with other substances to make the somatostatin analog sustain release. It also maintains very stable blood levels for the period of time when it's used. 80 days after administration, 80 to 85% of the drug is released. 150 days after administration, more than 95% is released. And in practical terms, it's very good giving it one time every 4 weeks, and you maintain really good blood levels throughout the entire month. The toxicities of Lanreotide are almost identical to that of octreotide, and everything you see here is also a side effect of octreotide or sandostatin. And we've talked about these types of things before. Most of these side effects being mild, and most of them not affecting most people. And really severe side effects are uncommon. It can make diabetes a little bit worse, sometimes a little bit better. It can cause a little bit of hair loss, but not usually. It can occasionally cause pancreatitis, diarrhea. It can cause soreness at the injection site, but it's not quite of the same magnitude in most people as deep IM injections. So to further evaluate this, there are two major international studies going on with Lanreotide. We've been quite active in both of these. One of these is for people who have so-called non-functioning enteropancreatic endocrine tumors. This means people that don't have carcinoid syndrome with flushing and diarrhea, but just have carcinoid tumor, or people who have pancreatic neuroendocrine tumors who are not having specific functional syndromes like glucagonoma or gastrinomas and the types of functional tumors making specific hormones. The objective of this study is to evaluate progression-free survival and quality of life in neuroendocrine tumors, to monitor the effects on blood products like chromogranin A, to check for antibodies to this substance, which has not been a clinical problem so far, and evaluate blood levels. The substance is given at a dose of 120 milligrams per day. It's possible to give quite a good dose when you have a long-acting subcutaneous injection. You're more limited in volume when you're giving IM injections in the usual way with other somatostatin analogs. So 200 patients are being randomized to receive either Lanreotide autogel 120 milligrams or placebo every 4 weeks. And as I said, the tumors should be non-functioning, metastatic and or inoperable, positive octreotide scan within the past 6 months, so we know that they have type 2 somatostatin receptors capable of interacting with these medications, the Ki-67 proliferative index below 10%, or mitotic count, which is low. In other words, people that have high-grade neuroendocrine tumors are not included in this particular study, and a performance status by the WHO criteria of not greater than 2, which means people are basically out of bed, walking around, functional for more than half of the day, which is at least. So this is a very important study, and I think would establish the role of Lanreotide as a treatment not only of symptoms, which is another issue, but as a means of controlling cancer in a similar manner to octreotide as shown in the PROMID study. The second major study with Lanreotide is for people that have carcinoid syndrome with flushing and diarrhea. Okay? This is called TR321 is the name of this study, for people who have pathologically confirmed carcinoid tumors, positive octreotide scan, a stable tumor over a 3-month period, and patients have not been treated before with somatostatin analogs or are responsive to conventional doses of somatostatin analog. So we'll keep an eye on this drug. I think that when it becomes more readily available, it'll be wonderful. There are patients right now who are receiving Lanreotide not on clinical trial but it depends a lot on insurance companies what happens when you use an off-label drug. Many insurance companies are denying it, and the surest way to be on the drug is to be on a clinical trial, but some lucky people are on it off trial right now as well. Okay, the next item I wanted to talk about is called SOM230, also known as Pasereotide. Pasereotide is another somatostatin analog. These are the triad of clinically available things right at the moment: octreotide, lanreotide, and the last is Pasereotide. So what is Pasereotide all about? Pasereotide is another somatostatin analog, very similar in chemical structure to the other two, but it has improved binding to the so-called somatostatin receptor, which is on the membrane of every cell in the body. Somatostatin and somatostatin analogs have to stick to the cancer cell by binding to the somatostatin receptor. And it turns out that the somatostatin receptor has 5 subtypes that bind to somatostatin. When analogs of somatostatin are made, they don't bind as well to these receptors. And, for example, octreotide binds to type 2 of these receptors and a little bit to type 5. Pasereotide binds to 4 out of the 5 receptors, to the somatostatin receptor subtype 1, 2, 3, and 5. And in addition, it binds to receptors with a higher affinity. It sticks tighter than the other somatostatin analogs, which gives a hope that in patients who are not able to be controlled with the other somatostatin analogs, that this is another drug that may be more potent. It also is very good at suppressing IGF-1, which is a stimulus to neuroendocrine cell growth. I talked about yesterday antibodies to IGF-1 receptor, which is another new direction that we're going in therapy. In the phase 2 trial that was done recently, toxicity was mild and very similar to octreotide. Some people had abdominal pain, nausea, weight loss, fatigue, a change in their blood sugar. But again, these side effects were usually mild and usually did not make people want to stop using it. The benefits outweighed the risks. 45 people with resistant flushing and diarrhea were evaluated on a phase 2 trial, which has been recently completed. And the SOM230 improved the carcinoid syndrome in 25% of patients that were resistant to control with octreotide. So it does have that extra benefit, which was predicted by its chemical structure and preclinical data. Encouraged by that, a large randomized phase 2 trial was done. Actually, it was a randomized phase 1 with 3 different doses of Pasereotide. This was a multi-center study. The initial dose of Pasereotide was given subcutaneously, just to make sure that people were not having any acute adverse reactions to the medicine, and then IM injections of 20, 40, or 60 milligrams every 28 days to assess safety and efficacy, to assess primarily safety of the drug. Metastatic carcinoid tumors of the digestive system and elevated levels of tumor markers were enrolled in this trial. Metastatic disease was resistant to octreotide. They had flushing and diarrhea. There were 42 patients with an average age of 60. Steady state blood levels were achieved after 3 injections. In other words, you achieved a maximum blood level and you stayed at that blood level after 3 months of treatment. The concentration of Pasereotide in the blood was similar to that was achieved in the previous studies done using subcutaneous injections twice a day, which now means that this medicine can be used safely and effectively as a once every 28-day injection, which is certainly more user-friendly than having to give things a few times a day. Side effects, again, very similar to the other somatostatin analogs. 25 out of 42 patients did have some type of toxicity, which was generally quite mild, including a little bit of diarrhea, nausea, malabsorption, or steatorrhea, which results from a deficiency of pancreatic enzymes, easily fixed by taking a pancreatic enzyme supplement, irritation of the injection site, asthenia, which is just a general malaise and not feeling too good, and a rise in blood sugar of 12% of patients had a rise in blood sugar, which, although the side effects, as I mentioned, were very, very similar to octreotide, one side effect was just in the rise in blood sugar was slightly more frequent than it was in people with who are getting octreotide. The rise in blood sugar resulted in needing treatment for diabetes with a pill in about 7% of people, although altogether about 12% of people did have an increase in blood sugar. Hemoglobin A1C, which is another measure of blood sugar control, increased slightly when people were on this medication. So conclusions, this is a promising new treatment for carcinoid syndrome, generally well tolerated, most common side effects, mild GI problems, injection site reactions, fatigue, and increase in blood sugar. Steady state blood levels were achieved after 3 months, and phase 3 trials are now going, and we're anxiously waiting the final results of these, and also we're quite active in these phase 3 trials. The first of the phase 3 trials I wanted to talk about was a multicenter randomized trial of Pasereotide-LAR versus octreotide-LAR. So some people got Pasereotide, some people got octreotide, and I'll show you how the study works. Patients treated with octreotide or Lanreotide who had inadequate control of diarrhea and flushing from carcinoid syndrome were eligible. And people were randomized between SOM 230, 60 milligrams per day, which is the highest dose that was used on the previously described randomized phase 1, versus octreotide in a high dose. So these were people who did not have good control on octreotide 20 or 30 milligrams every 4 weeks, which is the highest standard dose. They're randomized to Pasereotide versus extra high dose of octreotide, which is actually given in a specially prepared formulation so that you have 40 milligrams in the same volume that normally has 30 milligrams. So one injection in one buttock could provide 40 milligrams for people that are on this trial. It's not a commercially available formulation of octreotide. So the patients treated had poor control of their symptoms at the time they went on trial. That study is nearing fruition, and I think is something that will be very, very important. And other studies looking at its effectiveness in controlling tumor growth as well as controlling symptoms are also anxiously awaited, but we're certainly hopeful. There's another study that I wanted to mention, which is an open-label, multi-center, single-arm study of Pasereotide. Single-arm study means everybody gets Pasereotide. It's not randomized. The other study, by the way, everybody gets Pasereotide also. The randomized trial with octreotide, everybody who gets octreotide is able to be crossed over to Pasereotide. So everybody gets it. Half the people get it on day 1, half the people get it later. So the randomized trial, also everybody gets Pasereotide eventually. This study here, everybody gets it on day 1. This is for functioning pancreatic tumors. Islet cell tumors is another name for these tumors that make insulin, gastrin, VIP, and glucagon. It's also available for people who have tumors making ACTH, that have Cushing's syndrome, which is something we talked about yesterday. And also included in this study are some rare pituitary tumors. All patients receive Pasereotide, as I mentioned. So I think those are the major developments in somatostatin analogs in 2010 I just wanted to bring to your attention. Thank you. And